We are going to demonstrate the forces applied in the cervical, thoracic, and lumbar and lumbosacral spines with flexion, distraction, decompression, spinal manipulation. Now we talk about evidence-based clinical practice being three things. It's research, it's clinical expertise, and then it's patient preference. I'd like to share that I think we're going to show you all three of these things in this system. Number one will be research. Then this will develop into the clinical expertise, and we'll even show you studies that we have done showing the patient preference of differing forces with Cox flexion, distraction, decompression, manipulation. We'll begin with the lumbar spine, and I would cite several papers for you. One of them delivered in 2004 after our first federally funded study on the biomechanics of this technique. This was presented by Dr. Ram Goudavali as a platform presentation at the International Society for the Study of the Lumbar Spine in Portugal. And the second one of these was published in European Spine Journal, in which we compared the clinical outcome of this technique versus medical care at Loyola Street School of Medicine in Chicago. And so to outline these studies for your understanding, when we apply this technique to the lumbar spine, the forces that you will be taught to apply are specifically these, that we will apply a technique with the forces in the low back that will measure a P to A force on the spine in a novice doctor, one who has never done this technique, that to preload the inferior superior, the PA force, will be approximately 10 pounds or 46 newtons by a novice doctor. But following training with the forces that we are going to teach you here, in which you will see applied in the certification course of this technique, a novice doctor will learn to be applying a preload of not 10 but 15 pounds or 69 newtons of P to A force. Then the peak force that is applied has been found to be 23 pounds or 102 newtons. We'll show you the measurements of these forces on the force plate shortly. The force that we apply before training on an inferior to superior, that is the cephalward force that we apply to a given vertebra in, say, the treatment of spinal stenosis due to disc herniation or due to degenerative ligamental flavial hypertrophy, facet change, and disc bulge. Those forces before training of a novice doctor were about 4 pounds inferior to superior, the cephalward force. After training, we increased those to 7 pounds or 31 newtons. The reason I mention that to you is that notoriously we find not enough P to A force and cephalward force is being applied as we apply flexion, distraction, and decompression of the spine, whether manually or automated applied. Now the peak force of inferior to superior, that is the contact under the hand towards the head, the cephalward force, in a novice doctor beginning is only 9 pounds, but once we get them trained, that pressure will be 12 pounds that you will be applying under the spinous process above the level that you are decompressing. So that the papers that have been published on this, and one of them quite interesting is about the drop in the intradiscal pressures as we apply the forces that we are showing. The drop in intradiscal pressures in the 9 cadaver studies that we did, one dropped a negative 39 millimeters of mercury, where the normal would raise a column of mercury 25 millimeters into the air. And the maximum drop was 192 millimeters of mercury during this procedure that we will be showing you. So there's a marked decrease in intradiscal pressure something that's been discussed in medicine quite extensively. That's the paper that was presented in the International Society of the Study of the Lumbar Spine in Singapore in 2004. We also measure the other forces of lateral flexion, circumduction, and flexion all combined. And we find there that we measure the pressures and find drops in all of these as we laterally flex away from the side of the stenotic canal. That paper was presented as well in 2005. Another paper is an abstract from a bioengineering conference that Dr. Ram Goodavali, who is the principal investigator of this work, which he presented on the intervertebral disc changes in the spine. And so we've had several papers published in refereed journals, finally culminating in this study in the European Spine Journal, volume 15-6 in 2006 on page 1072. And this particular paper was of interest because it compared, it was a randomized clinical trial and subgroup analysis of flexion distraction versus active exercise for low back pain. And in this paper, the technique which you're going to see for low back chronic pain found that the radicular patient had about 250% better relief from this technique, Cox flexion distraction decompression, than they did with physical therapy. Now we're also going to be talking about the cervical spine and the forces that we apply to the cervical spine. And we're going to talk about intradiscal pressures in the cervical spine as well. We're going to see that in the neck, the posteroantral force that we apply to a spine, the P-day force, whether we be treating, and usually in our studies we're using foramen magnum pump at the basi-occiput, or C5, which is the most common level of disc herniation stenosis that we see in the cervical. You're going to see that the PA force that you use is approximately 82.6 newtons, which is about 18 pounds, and the mean traction force, the cephalward force applied to the cervical spine, is as high as 119 newtons, or about 26 pounds. This particular paper, which you can get, which you'll see us present in lecture in didactics, it was published in the Hyundai Publishing Evidence-Based Complementary and Alternative Medicine in 2013. In that publication, that was done by Dr. Goodavali and the researchers at Loyola Street School of Medicine, Palmer University, and Heinz VA Hospital. Then we also did a test and published a paper in Trials, a journal called Trials, which was published in 2015, volume 16. And it's where we took three forces and applied them to the cervical spine. We applied a cephalward force from 0 to 20 newtons, which is about 4.5 pounds of traction. Then we used 21 to 50 newtons, which is approximately up to 5 to 11 pounds of traction. And then we used 51 to 100 newtons, which was 11 to 22 pounds of distraction. And this study was done on 48 patients who were randomized to all three forces, and the doctors who were doing this were trained by actually auditory and visual measurement of those newtons of force, so that we knew how much was being applied at two levels, one at the occiput, the other at C5. So we measured those forces, and the doctors, they were trained in how to measure these forces. And in this study, we found that in these 48 patients were treated 5 times over a 2-week period. And the traction forces were measured. The subjective outcomes were measured by the VAS score, the neck disability score, and a credibility and expectancy questionnaire. Throughout this, and I'll show you the results, we found no serious adverse effects from this technique in treating the cervical spine. Then this paper was published in Spine Journal, and this was published in volume 15 in 2015. It's about how proficient were the clinicians at applying these three various forces to check clinical outcomes and patient preference. And we found that, the clinicians, when they delivered 5 manual cervical distraction treatments over a 2-week period on the patient using these 3 forces, we found that the clinicians were treating that the interdependent testing showed that they were very accurate on measuring the forces, and again, no adverse reactions were found. So having given you that brief outline, we're going to now demonstrate these forces being applied. You see the published papers for your edification to read. You'll hear this in didactic lecture, and now we will visually show you the application of these forces in clinical practice. Now here is the application of manual flexion, distraction, decompression of the lumbar spine. Hand contact on the spinous at L4. You'll note that with my hand contact, I'm starting there at a force of approximately 55 newtons. So when I apply flexion distraction, you'll see that it's going to be a very smooth, very rhythmical, very oscillatory movement. And you can see that I'm applying here from approximately 30 newtons up to 75 newtons. So I'm putting about 45 newtons of force onto the spine. So 45 newtons means I'm somewhere just about 10 pounds per segment. So you'll note there's a very smooth, rhythmical application of force. And this is manual. So this is a manual force application. Very smooth and rhythmical. We do this at 5 repetitions in 4 seconds, as you see going right here. 20 seconds, 5 reps consisting of 4 seconds on each repetitive flexion distraction. So you see that the forces are equal, they're smooth, and they're rhythmic. That's what we will attain in teaching this in didactics and on certification exam. Now here's long y-axis automated distraction. Now you'll note that when you use long y-axis automated, you see it's much greater force. So when you're using long y-axis automated, you can see that I'm going up there at a much higher force. In fact, I'm going from approximately 20 to 180 newtons. So that's 160 newtons. That's that's a lot of force. So if I just bring it down gently, I can begin to mimic the lower forces of around 11 to 15 pounds, which is quite desirable in treating a lumbar disc. So there would be your automated force. Just remember that when you're using long y-axis automated, that you don't use nearly the force that you do when you're treating manually. Okay. So we'll be demonstrating this to you in didactic lecture, and you can measure the force. You can record it on one day, on subsequent days with the patient, so that you can tell as healing progresses that they can tolerate and withstand and actually need greater forces to relieve spinal stenosis, whether due to disc herniation or degenerative change. In summation, therefore, here would be the 5 4-second pumps for one of the 3 repetitions that we use in flexion distraction. Hand contact It would be 1, 2, 3, 4, 5. So this is the goal of you as a practitioner in applying flexion distraction decompression to a lumbar spine. 5 4-second pumps, here consisting of approximately 35 newtons of force, which would be somewhere around 8 pounds per segment. Okay?
Okay.
Now here will be the cervical spine long y-axis decompression. And I'm going to start with the frame of magnum pump, contacting occiput, taut point, and here would be the same 5 4-second pumps applied to the cervical spine. You'll note that I'm going from approximately 15 to 40 newtons, about 25. So we're looking here in the cervical spine distraction at about 25 newtons, which will be somewhere around 8 pounds of distraction force. Now, so the 5 4-second pumps at the frame of magnum pump will look like this. The 5 4-second pumps at the frame of magnum pump, they're called the frame of magnum pump technique. Now we move down to C5, and a couple of points here. We make the contact on C5, we place the spinous here, the laminae here of C5. We do not press on T1 as we apply long y-axis distraction, because that increases intradiscal pressure at C7, T1. So if you were treating an ulnar radiculopathy, that would be especially negative. We contact C5. We don't press P to A. We lift as we apply flexion to the taut point, and then apply our 5 4-second pumps looking like this. And I'm going here from 20 to almost 55 newtons. So I'm applying again about 25 newtons of force. So in essence, to show you the 5 4-second pumps, the contact, the taut point, 1, 2, 3, 4, 5. And note the rhythm, the consecutive force. Again, as we treat, we are constantly asking our patient, are you okay? Does that cause you any increase in arm pain or neck pain? If it does, we reduce the force to patient tolerance. So I want you to see the forces applied here. You can see we're going from roughly 5 newtons to 45 newtons. So it's about 30 newtons to 40, 35 newtons of force. And so that puts us somewhere in that 8 to 10 pound range, which is very comforting in a cervical spine. Again, all of these forces are always mentored by patient tolerance. How does the patient feel? Does it cause them any discomfort? So this is the very basis of applying long y-axis decompression. We will now show you measurements in more detail of other movements of the spine during application of flexion distraction.
Go.
All right, we're going to show today some different applications of ranges of motion, different amplitudes of force. You saw Dr. Cox perform the Protocol 1, 3 sets, 5 reps, 4-second hold. We're going to show some protocol 2 movements. So we're going to do 1 set of 10 repetitions with a 1-second hold time. The force application is going to look like this. Make the contact. Slow, rhythmical movement. Good. Always asking if the patient is okay. I think sometimes they feel like we ask them too much. You feeling okay, Dr. Cox?
I'm fine.
Any pain? What we're looking for on the graph is that you can see the lateral flexion and flexion angles. Cycle that we just did, straight flexion. You can see the cyclical movement. This is showing the table and movements as far as the number of degrees, each of these coming from neutral, dropping down in our cycles, back up. We're down 2 to 3 degrees of table motion, gives us 2 to 3 millimeters of ID disc separation, so that's what we're looking for under those. We're also looking for is my force. This is the long y-axis force that we saw over here. As Jim showed on the last one, we wanted pounds, about 10 pounds. We're seeing that cycled through here. So when we move into other range of motion, we're going to watch for this lateral flexion angle. We're going to unlock lateral flexion, open flexion. Slowly take that down. Taut point. We're going to go into lateral flexion of the right first, opening the left osteoligamentous foramen. Doc, you doing okay?
Fine.
Doing a unilateral movement where we're just doing lateral flexion of the table to the right, so we're opening the left osteoligamentous foramen. Have a small degree. We're moving someplace around 6 to 9 degrees. I'm going to move that back over to the opposite side. You doing okay?
Doing fine.
You can see on the graph the number of degrees. We're at 6 to 8 degrees. There was 9 degrees. Move back to neutral. And lock that in. Here was our lateral flexion treatment. This was all to the right side, moving through, moving back over to the left side, 10 repetitions on each side, and then back to the neutral force. We're going to go into long Y. Drop the table to taut point. Using the tiller bar, slowly move out to a comfortable zone. As Dr. Cox just had instructed on, you want to be very cognizant of how far that table goes out. The forces are much stronger when we use long y-axis application. Doc, you doing okay?
I'm fine.
Smooth, rhythmical, oscillatory. Back to neutral. There's my long y-axis force. As we delivered that, you can see that in conjunction with the thoracic forces, both even, smooth, rhythmical, oscillatory. 3 sets, 10 repetitions, 1 second hold. That's our protocol 2. Next we're going to show the application of delivering long y-axis force for thoracic manipulation. What you'll find is that it's very comforting for the patient, and it doesn't take a high impulse thrust at all. You'll just see the contact gently moving down. I'm using the foot piece to run long y-axis. Very smooth, very rhythmical, very oscillatory. Very little P to A force is being delivered. And it's very common to have cavitations under the long y-axis force. You can feel for that range of motion. If they do need 2 or 3 cycles at one segment, continue on after you've achieved better range of motion into that joint. Going back to the computer, there's my long y-axis force. is the amount that we're pulling out. Again, you'll see the forces in the thoracic spine. You'll see these starting to move simultaneously. Very smooth, very rhythmic, very oscillatory.